everyone, my name is Laura Zimmerman. I'm a nurse in the MSICU and I'm also the MSICU's Delirium champion. Today I'm going to talk about the assessment of delirium using the CAM-ICU and managing and preventing ICU delirium. Delirium defined is a disturbance of consciousness with inattention, usually accompanied by a change in cognition or perceptual disturbance that develops acutely and fluctuates over time. That being said, there are two cardinal things to that I just read. One is inattention. You must be inattentive to have delirium. Inattention is just the ability to concentrate on something or the ability to appropriately shift concentration to another item. The second part of delirium that you must have is that there must be an acute onset that fluctuates. So you must have these two things in order to be considered delirious. So causes of delirium are still being debated. The exact pathophysiology and etiology are debated, not really known or understood. However, researchers do believe that it's related to imbalances in neurotransmitters. These include serotonin, acetylcholine, GABA, and dopamine. And these neurotransmitters help control your cognitive function, your emotions, and mood. So there's a few different triggers, or actually not a few, I should say. There are many triggers and causes believed to attribute to this neurotransmitter imbalance. Basically, it's anything that can cause stress on the body, immobility, restraints, medications, that's a huge one, sleep deficiency or oversleeping, hypoxemia, dehydration, you name it, it can cause delirium in the ICU. There's, I think, about 100 different things that an ICU patient can be exposed to that will cause delirium. So there are three types of delirium. The first is hyperactive delirium or ICU psychosis, and this is what you kind of think of when you think of delirium. It's combativeness, restlessness, agitation. However, this only occurs in about 1% of delirium cases. This is frequently noted in people with alcohol withdrawal. The second type is hypoactive or quiet delirium, and this occurs in about 35% of ICU patients. And this is shown by patients being a little bit withdrawn, maybe a little quiet. It is harder to notice these patients or diagnose these patients. They just seem like they're a little bit down. The most common type of ICU delirium is mixed delirium, and that is a combination of both the hyperactive and the hypoactive. This occurs in about 64% of ICU patients. Again, it's a mix, so you might have periods of agitation and then a few hours later some somnolence, kind of fluctuates throughout the day, and that is the most common type that you'll see. There is something called rapidly reversible sedation-related delirium. That's a mouthful. It does represent about 12% of hypoactive delirium cases. And you'll notice this in patients who are currently on sedation. You'll go in, try to assess for delirium using the CAM-ICU. However, they'll be pretty lethargic, usually like a RASS of -3, -2. So you might try to do the CAM-ICU and they just fall back asleep. That is a CAM positive. However, within 2 hours, you should reevaluate 2 hours after their sedation has been turned off and do another CAM-ICU. And a lot of times, these patients will no longer be CAM-ICU positive. That, again, is the rapidly reversible sedation-related delirium. The prognosis is similar to patients who have never been CAM-ICU positive. However, if you do come across this, you should definitely chart it. It's something that should be followed up on, especially 2 hours after that sedation has been stopped. Another, it's not necessarily a real type of delirium, but it's something called subsyndromal delirium, and it occurs in patients who seem a little bit off. They might not be making much sense, might just seem kind of like they're getting delirious. However, when you go and do the CAM-ICU on them, they do not have that inattentiveness. This again is not a real delirium, but it's kind of a precursor to delirium. So if you notice this in your patients, you should be doing CAM-ICU a little bit more frequently on them, like every 4 to 6 hours. So common signs of delirium, which most of you know, is lethargy, decreased language perception. They don't seem to understand what it is you're saying. Disorientations, memory impairment, also inattention, hallucinations, delusions, emotional disturbances, agitation. However, it should be noted that a lot of times these symptoms they might be showing are so subtle you don't notice that at all. That's why you need to use the CAM-ICU to assess for delirium. So I know most of you know delirium is not a good thing, but I don't think many people really understand the significance it plays. So delirium, it attributes to longer hospital stay, longer mechanical ventilation, increased mortality, and that's not only while in the hospital, that's also a year out of the hospital after discharge. It also plays, obviously, greater long-term cognitive dysfunction, greater costs, and it can also attribute to something called post-intensive care syndrome, or PICS. And as noted in the slide here, 50 to 80% of mechanically ventilated patients, or 20 to 50% of non-intubated patients, will develop delirium, which is significant. That's huge. So here's some pretty interesting statistics. Delirium more than doubles your risk for mortality while you're in the hospital, which is huge. For every day of delirium that you have in the hospital, it'll increase your hazard or your risk of dying by 10%. It also increases the cost of hospital stay by 39. Some people are saying even more, up to 50% of your hospital stay. And it has an estimated collective healthcare price tag of more than $143 billion just in the US. And again, there's more studies showing that this estimate might be low, it might be much higher. This is continuing on the statistics. So in patients who were delirious during their hospital stay, this includes just 1 day of delirium, a third of those patients mentally and physically stayed the same as the day they left the hospital. So this means that, you know, most times if you've been in the ICU, you're going to require rehab afterwards. This means these people stayed the same despite everything. They are not functioning at what they were in the past. A third of these patients will actually decline and get worse mentally and or physically, and only a third of those patients will improve, hopefully back to their baseline before coming into the hospital. This I found very interesting. At a 12-month follow-up, patients who were delirious during their stay, about 2/3 of them, 67%, had cognitive function scores similar to those with a moderate traumatic brain injury. So, I mean, it really is devastating. And about a third of those had a score as abnormal as someone with mild Alzheimer's. So it's definitely something not to be taken lightly. It's not something you go into the hospital and they get delirious and, oh, you know, they'll be delirious, so what? It really does affect them afterwards. Another thing found in about 2/3 of patients who were delirious in the hospital is that they'll develop this post-intensive care syndrome, or PICS. And that is something that will linger on with them probably the rest of their lives. So just to touch on this PICS, it's a disorder of new or worsening impairments in physical, cognitive, and or mental status, which arise from your critical care illness and interventions that persist beyond your acute care hospitalization. So it's found in about a quarter of patients who've been in the ICU who did not develop delirium, and about, as I mentioned before, 2/3 of previously delirious patients. These numbers, the 2/3, is similar to those who've been in war or rape victims, so it's quite a large number. And these symptoms include anything that can be found with PTSD, depression, suicidal ideation, suicide attempts, anxiety, grief, anger, and it can also affect your motor function as well. This they're finding is more and more common, and it's very, very unfortunate. We are part of a collaborative. It's an A through F collaborative. The A, B, C, D, E, F is a mnemonic of different delirium interventions, per se. We've been a part of this, and we've collected some data, and it showed that we have decreased the ICU stay by 2 days, and that's just starting. We're still getting this rolling. To go through each element, A is to assess and manage and prevent pain using a numerical scale, so like 0 through 10, or a CPOT, which is a critical care pain observation tool in patients who are nonverbal. So, and we make sure we treat pain first. That stands for the A. B is making sure that both a spontaneous awakening trial and spontaneous breathing trial have been completed, which our facility has been doing. We're almost at 100%. C stands for choice of sedation and analgesia. Sedation being trying to stay away from benzodiazepines and sticking more with propofol or dexmedetomidine. D is delirium, which we're going over here. So delirium assessment using CAM-ICU, managing and preventing delirium with various interventions, which I'll touch on later. E is early mobility, so getting your patients up and moving. And F is family involvement and empowerment, to make sure that they're involved with the patient's care as well. So now we're going to touch on the CAM-ICU, which is extremely important and will be the majority of the rest of this PowerPoint. So the CAM-ICU is a valid, reliable, and feasible method of assessing CAM or delirium in the ICU. Has about a 96% sensitivity, so that's quite high. It's actually the highest form of measuring delirium. It yields 3 results: positive, negative, and unable to assess. About 90% of CAM-ICUs take less than a minute. It's very, very quick. The other 10% will take no more than a couple minutes. And again, without appropriate use of this CAM-ICU, about 28% of delirium days will be noticed. The rest will not be identified. So it's quite important you're doing this, even on your patients who seem like they are not delirious. So RASS scoring, this is very important. As you know, RASS score stands for Richmond Agitation Sedation Scale, and that might be a misnomer, might be a little confusing. This is used on patients who have not even received sedation. It could be on patients who have, and also patients who have not. It's just measuring how either agitated, awake they are, or how lethargic or sedated they are. It ranges from a score of +4, which meaning you're extremely agitated, aggravated, down to a -5, which is comatose or paralyzed. So to go more into depth on the RASS scores, we're going to go through them one by one. We're going to start with +4, which is combativeness, extreme agitation. So with a +4, your patient's going to be, trying to attack you, hitting you, kicking, trying to cause you pain. It's purposeful. We don't see that all that often, but when you do, it's not good. +3 is very agitated, and that's when the patient is purposely pulling at things, like pulling at restraints, other lines, trying to extubate themselves. It's purposeful and it's pretty aggressive. +2 is agitated, so it's not necessarily a purposeful movement. They're just agitated. They're kind of like moving around, more than fidgety, still kind of pulling on things, but not necessarily purposefully. Could be fighting the ventilator. +1 is more of a restlessness or anxiety state. So you're, a little bit fidgety, might look a little bit uncomfortable, just kind of, moving around, tapping your feet, not able to sit still. 0 is what you and me, what I am right now. I'm alert, oriented, not anxious, and not also not lethargic. Just kind of what everyday people are like. -1 is someone who's somewhat lethargic. You're still able to maintain eye contact with someone for greater than 10 seconds. Can still hold a conversation, but you're a little bit lethargic, a little bit sleepy. Maybe this is a patient who might have received some Dilaudid or something like that. Might just be a little bit snoozy. -2 is light sedation. So these patients will make eye contact, but it's for no more than 10 seconds. So they'll be able to make eye contact, can have somewhat of a very short conversation, or again, as long as they're making eye contact with you for less than 10 seconds. -3 is moderate sedation, and that's when someone will not make eye contact with you, but they will either open their eyes or move to verbal stimulation. So again, you walk in the room, they don't elicit a response, then you say their name or say, hey, can you open your eyes? And if they just kind of move or do something, that's considered a RASS of -3. However, if you go into a patient's room, try to verbally elicit a response and nothing happens, you go and touch them, you sternal rub them, you could even suction them, and you do elicit a response. Again, no eye contact, but they might shrug their shoulder or move or open their eyes. Again, no eye contact. They are considered a RASS of -4. This is considered deep sedation. It is considered a comatose state. And again, we don't see this all that frequently in patients who've been in the ICU for a while. This might be someone right after surgery or maybe a couple hours after surgery, or someone who's being heavily sedated, like 4 and 400 of fentanyl and Versed. -5 is unarousable, and this is obviously a comatose state. This is when you cannot elicit a response either verbally or physically. These patients are either snowed on like 600 of fentanyl and Versed, or maybe paralyzed, or unfortunately could be brain dead. No matter what you do, you cannot elicit any response. So alert and oriented patients, they can be delirious. Being alert and or oriented is not the same thing. It's not synonymous with being delirious. You can have someone who appears perfectly normal, talking to you. Again, you ask them what year it is, they know. However, they have this inattention when you do the CAM-ICU. So we should not be hearing, my patient's alert and oriented, therefore they're CAM negative. That's not true. Unfortunately, you have to go on and do the CAM-ICU. So there are 4 features of CAM-ICU that you need to know. The first one is acute change or fluctuating mental status or mental course. The second is inattention. The third is your altered level of consciousness at this particular time. And then the fourth is a disorganized thinking. So feature 1 is acute change or fluctuating mental status. It's just a yes or no answer. So has this patient in the last 24 hours had a RASS other than 0? Or has their mental status from baseline changed at all? If the answer is no to both of those, which is usually not the case in the ICU, then you are done. They've had no fluctuation, no changes, then they are CAM-ICU negative. However, I would again say like 99% of the time, patients have been getting analgesics. They might have a RASS of -1 for like even just 5 minutes. Then you're going to proceed on to feature 2. So feature 2 is inattention, and as I mentioned at the beginning of the presentation, you have to have inattention to be delirious. So to test this, it's pretty simple. You ask the patient to squeeze your hands, and every time you say the letter A, you want them to squeeze your hand. You can say a series of letters. It doesn't really matter as long as you have 4 A's in that 10-letter sequence. So you can say abba-dabba-day, save a heart, but heart spelled with 2 A's, anything that your heart desires, but you just have to have 10 letters in total and 4 A's. Again, if they can't squeeze your hand, you get creative. There's other ways. You can ask them to blink, to nod, to wiggle their toe, as long as they can do something repetitively. If they have 0 to 2 errors, then they are considered CAM-ICU negative. However, if they have greater than 2 errors, then you have to proceed to feature 3. So feature 3 is quite easy. It's just altered level of consciousness. So you're just looking at what their RASS is right at this time. So we went through that. So again, RASS +4 to -5. If it's anything other than 0, then they're considered CAM-ICU positive. If they had the inattention and have a RASS of 0, you have to proceed on to feature 4 of the CAM-ICU, which is disorganized thinking. So again, most times this person's not going to have a RASS of 0, but occasionally they do. So feature 4 of the CAM-ICU is the disorganized thinking questions. Again, you won't get onto this feature 4 unless 2 things. 1, your patient does not pass the save a heart or the inattention, they squeeze incorrectly, and the second part is they have to have a RASS of 0. So you're not going to go on to this 4th part all that often, but it does happen on occasion. This disorganized thinking portion, or feature 4, has 2 parts to it. The first part is these questions, they're yes or no disorganized thinking questions that you go through, and the second part is the command portion. There are a total of 5 points that people can get on this, 1 for each question, and 1 for completing the entire command. For the 4 questions, there's these 4 that I'll mention in just a moment, and 4 on the next slide that are approved. One is, does 1 pound weigh more than 2? The other one is, can you use a hammer to pound in a nail? Third is, are there fish in the sea? And 4 is, will a stone float on water? They should just give you a yes or no answer for these. It should be pretty quick and to the point. For the command portion, what you're going to do is you're going to do this, and you're going to ask the patient to hold up this many fingers. You don't want to say, hold up 2 fingers or whatnot. You just want to demonstrate, just say, hold up this many fingers. You should watch them do that, and if they do that, then say, now do the same thing with the other hand, and then they should demonstrate that. Again, you shouldn't demonstrate that to them. You should let them just do that using your verbal command. If they have physical limitation on one side, you can say, instead of saying hold up or now do the same thing on the other hand, you can ask them to add 1 more finger to it. So they'll go from 2 fingers to 3 fingers. If your patient has no or has complete physical limitation or no movement, motor function on their hands, or is blind, you actually don't need to go on to the command portion. You'll score them solely off the disorganized thinking questions. This being said, if they get more than 1 error, meaning they miss 2, either 2 questions, 1 question, 1 the command, then they're considered CAM positive. If you're going through the 4 questions and they get 3 of them right off the bat wrong, you don't even have to go into the command because it's obvious they've already missed 2 or 3 points. This is a little bit more tricky. So CAM-ICU in patients with neurological conditions, either dementia or stroke or a traumatic brain injury, you can accurately assess CAM-ICU if you have an understanding of what their baseline is. In these patients, usually hopefully you'll talk to a family member or a physician that knows them well, like maybe from spinal cord or from any other multidisciplinary team. You just want to have an idea of how they normally are if they're functioning at baseline. If a family member or a friend is present and they're very familiar with the patient, you can ask them, is this normally how they've been? Has anything changed? You can go on and perform the CAM-ICU on these patients and kind of see how they do. And then if there's a family member nearby, you could say, normally can they perform that? And normally can they follow these commands and squeeze appropriately. If they say no, they normally can't, this is their baseline, then they're CAM-ICU negative. There's no additional delirium on top of their neurological problems. So the frequency of CAM kind of varies. It should be done every 8 to 12 hours on patients who've had consecutive CAM-ICU negative scores. However, if they do have a positive score, then it should be done about every 4 to 6 hours until they've been CAM-ICU negative for about 24 hours. You should also do it, as mentioned before, 2 hours after stopping all sedatives and after extubation. Just sometimes the sedatives need a little bit of time to get out of the system, so that should be done as well. Again, PRN or with any type of mental status change, you should obviously do CAM-ICU just to see if they've become delirious. And although this should be noted, although a patient may be CAM-ICU negative, if they've had CAM-ICU positive scores in the last 24 hours, they are still considered delirious. They're no longer considered delirious after a full 24 hours of consecutive CAM-ICU negative scoring. So preventing and reducing ICU delirium in the ICU there's a few things. Treating pain first. So if a patient is agitated, you should probably go ahead and treat them with a pain medication rather than a antipsychotic, because usually agitation is brought upon by pain, and maybe it's just pain that hasn't gone noticed, hasn't been treated well, so treat pain first. The second is to promote consciousness. You want to ensure your patient is awake during the day, not heavily sedated if they don't need to be, and up and moving. Another is weaning mechanical ventilation. As mentioned before, patients should all have spontaneous breathing trials when it's appropriate, when it's safe, and spontaneous awakening trials, meaning you get off sedation. The fourth is increased mobility. This is huge. As mentioned before, this is the most effective and only proven way to reduce the duration of delirium. So it's really important that on day one you start mobilizing your patients or attempting to if it's safe. Another thing that's really important and shown great improvement on reducing incidence of delirium is increasing your patient and family participation, including them in rounds, informing them what's going on, letting them help out, if you're ambulating or moving the patient. It's important that they're involved. And by doing these things, you can reduce complications associated with delirium, you can reduce delirium and improve patient outcomes. So non-pharmacological delirium management strategies, there are a number of them, and these should all be tried first rather than just trying to give a medication. So it's really important you start out mobilizing your patient early. Everyone should be mobilized on day one. Even if they are paralyzed, it's been proven that passive range of motion can actually reduce the incidence of delirium. So that's quite important. Mechanically ventilated patients are not excluded from early mobility. When it's safe and appropriate, you can ambulate these orally intubated or trached patients. And again, as I mentioned, early mobility has been shown to reduce the duration of delirium by half, which is huge. It's the most effective intervention in delirium management. Sleep hygiene and sleep enhancement is also extremely important, making sure that their daytime and nighttime hours are normalized, so trying to keep them awake during the day, try to keep them engaged, out of bed to a chair with the lights on, maybe let them look outside, and at night trying to reduce interruptions, letting them sleep, reducing noise in the ICU, that can help. You can give them earplugs, eye masks. You could try to talk to other members of the team, respiratory therapists, physicians, about clustering care. If you're going to have to interrupt and wake up a patient in the middle of the night, try to do it at once. That will help as well. And it should be noted that nighttime sedation, so putting someone on like Dex or Versed or something overnight to let them sleep, is not the same as sleeping, and that doesn't really count as nighttime normalization. So to continue on with some more non-pharmacological management of delirium. There's frequent reorientation. Make sure that you're reorienting them, saying who, what happened, where are you, why are you here, and then how did you get here. It's important to make sure that a clock is nearby so that a patient can at least keep track of time. Just let them know if it's daytime or nighttime. It's also important to use their sensory assistive devices like glasses or hearing aids, dentures, that can all help. And then I just wanted to read you a quote from a patient who was delirious and trying to explain what they were feeling when they were delirious, and I thought it was a very powerful statement. "The time I spent seems like it was in a huge, empty gray space, sort of like a monstrous underground parking garage, with no cars, only me, floating or seeming to float on something. Every once in a while, I would get to the edge of something horrible, and I thought, if I just let go, then this horror will be over." So I just wanted to leave that with you, just to let you know what these patients are going through, and if we can do everything in our power to prevent this from happening, and hopefully, if it does happen, to reduce the length of time they have that.